my question. Am I going overboard because I did not ask specifically what kind of anemia, just whether they had it? We worry about the rest after we confirm she actually is anemic. Yeah, that is a problem. That's a really complicated question, but bottom line is, what you're asking is, when I order tests, how many tests do I have to order? And it seems like you're either under or over. And the problem is you're playing the case in basic, and it's a very linear case. You've got to think up front of all the tests you might want to order, even though in real life we would first order the test to see if she was anemic, get back the diagnosis of anemia, and then order the next appropriate one. Because if she had a macrocytic anemia, I would order one set of tests. And if she had a microcytic anemia, I would order a different set of tests. But here, since you have to order all tests, you have to really base most of your decision making on the history and physical. And when in doubt, it's probably good to order one or two things beyond what you normally would. We do have a configuration that's called advanced DDX, where you can order 3 or 4 different rounds of tests. You can change your differential as the test results come back. That is a more advanced type of configuration, but it is more similar to what we do in the real clinic. So it's really, you're just limited by the current configuration. So err on the side of ordering a few more. Also, for simplicity's sake, the test of an H&H was not available. It was only a CBC option. So if we were really only shooting for minimal testing, wouldn't an H&H cover it without the need for a differential? Yes. So question of, do I get a panel CBC, or do I just get a hemoglobin hematocrit first? And having practiced on both coasts within the United States and practiced across multiple decades, I can tell you that within different hospitals, within different locations, and across the decades, all of that has changed and come and gone and come and gone. So we're trying to create a product that's pretty generic. So we try to make it, again, pretty generic. In some institutions, the cost of a hemoglobin hematocrit is identical to a CBC. If that's the case, I would order a CBC, right? I'm not going to save any money, and I might get a little bit more information that would help me. If you look at thyroid function tests, as an endocrinologist, I know more about the endocrine testing, which is more expensive than some of the routine blood work. I get a TSH and a free T4. I never order a panel. Why? Thyroid testing is expensive. I also order both. I don't order the free T3 and all the rest, because the most of them are evaluating things that are either very rare or evaluating liver function and nothing to do with thyroid disease. But nobody talks about the fact that free thyroid hormone, that is T3, is the biologically active hormone. We measure some of the other things around it. Why do I always order a free T4 and TSH combined? If you go into primary care, if you go into family practice, they will only order a TSH. You can have resistance. You can also have things that don't make sense. And so I'm an expensive person to come see as a specialist. If you come back to me because the TSH doesn't make sense clinically with what I'm seeing, and now I have to repeat it, it's more costly than if I just ordered a free T4 and a TSH and I had a confirmatory lab. So it does get a little complicated. And the combined cost of those is less than a second visit. And now it's probably even less than a second visit that goes into a family practitioner. So you really have to be asking your thinking more generically. So CBCs and H&Hs are reasonably close in price. So opt for the one that gives you a little bit more information. But when you're getting specialty tests, then you have to think a little bit more carefully. So after we get clinical, we move on. We're not going to get clinical feedback because you're not playing these in learning mode. We're going to move on to the test. So in doing the physical exam, a couple of things that I would recommend. Notice there's a clock above her head. Notice that I can bring various pulse points on. I can also rotate the patient. You're not sure what all these icons do. Here's your little crib sheet. Again, if it's dark blue, it's a clue, it's a toggle switch. Also remember on the home page, there's an entire tutorial. So if I press the little question mark up here, it will take me to all the front home page. It will give me keyboard shortcuts. It will take me to the support center. So that's another way to get help. Definitely go to the home page, read the little tutorial on how to improve your score, the user's guide. That would also be really important. In doing the physical exam, one of the things that I'm really sort of surprised at a lot is that a lot of students don't start with vital signs. They are vital, V-I-T-A-L. You know, that was to sort of prompt you to think, okay, they're important. Why? It doesn't matter if you come in with a belly pain, sore, whatever your complaint. If you're hypotensive, all of a sudden, I have to take action and the urgency has changed. If you're tacking away at a blood pressure of 200 over 120, that is hypertensive emergency and I need to do something. So vital signs are important so that I know what to do. So take your vital signs. Anytime you have to listen to anything, get your stethoscope out. In a computer simulation, your stethoscope is earbuds or earphones that you plug into the computer. So I click on it. Now my cursor turns into a gloved hand. You should count for 15 seconds. If you read the Bates textbook, whatever the gold standard is for whatever you're doing, that's what we're holding you to, I'm guessing. Why? You're going to learn how to cut shortcuts, how to make it shorter when you're in the clinic. But the reason it's 15 seconds is in bradycardia, if you only do 5 or 10 seconds, you tend to underestimate the pulse. We want it as accurate as possible, hence the 15 seconds. Respirations should be the same. I don't know what she's doing. And again, you have to qualify it. Whether you did a mental status evaluation in the history, think about it, and then do it here. The rest of the physical exam, if you need to do a blood pressure, I'm going to move this over here. Pump it up and then you let it out. We're going to assess, did you pump it up to the top? I'm letting this out so it doesn't irritate us. You know, how high did you pump it up? Did you hear and accurately document the first and the last fret of sound? Did you choose to do an orthostatic evaluation? Let's say it was 120 over 80. And then did you appropriately qualify it as normal, hyper, and hypotensive? And yes, you guys probably all heard that in August 2017, there was at least 6 or 7 different institutions here in the United States that changed the definition of hypertension. Stage 1, stage 2. We now have normotensive, elevated blood pressure, stage 1 hypertension, stage 2 hypertension, and hypotension. We're in the process of making the engineering change to make that happen. But also remember, hypertension is a diagnosis. If you are seeing a person a single time, we haven't seen her before, during an acute illness, not the ideal time, you cannot make a diagnosis then of anything other than elevated blood pressure, hypotensive, normotensive, or elevated blood pressure or hypertensive, urgent or emergent issue. And that defines it with a blood pressure greater than 180 over 120. You can't give them a diagnosis of hypertension. We're asking you to characterize the blood pressure, not provide a diagnosis. So we will be changing this. You will notice a change. And then you have to determine, was the pulse pressure narrow or wide? You also have to decide if you want to do an orthostatic blood pressure will give you what the results are, and now you have to decide, is the person orthostatic? Everything you're finding on your physical exam, you continue to put over here on your problem list. So this problem list or key finding list is a list of all the things that either in the history or the physical exam were out of the norm. Do I need to put everything in the past medical history there? For me and the cases here, the answer is no. If your faculty tell you yes, please do whatever they tell you. For us, we want the things that are not normal, that are related. Does a past medical history sometimes get on that list? Absolutely. If a person came in with a respiratory problem and I found out that she had a history of cystic fibrosis, would I put that on there? Absolutely, because that totally changes my view. I do have somebody raising their hand. I'm going to unmute you, Mariana, and you can question. Sometimes with the number of you on, it gets a little dicey. So if you want to ask a question, it's probably better to just type it in. So how to move down through the list, we're having it head to toe. I can also type in things that I want to do. Let's say I want to auscultate the heart. I might do it that way. You have to listen to at least 3 cardiac cycles at each site to get full credit. Why? At the first one, you should be listening for the first heart sound, second heart cycle, the second heart sound, third heart cycle, everything in between. I usually listen for 5 or 6 in a real patient. I'm not great at hearing all those opening snaps, clicks, twicks, whatever. So I tend to listen longer than some of my colleagues, and that's okay. Figure out what you're good at, figure out what you need to spend more time at, and do whatever you need to do to be as accurate as possible. Stop worrying about what the rest of the people are doing. Auscultating lungs, you must do it in a pattern. Again, 2 or 3 breaths at each site, show an efficient pattern. This is all outlined in Bates. Turn the patient around, and again, we want to compare side to side to side. I know I've had individuals tell me, I only listen to the apices in the front, and all I'm going to tell you to do is to go into a textbook and look at the structure of the lungs, and then tell me why people always aspirate into the right middle lobe, and where can you best hear the right middle lobe. You will find you can hear the right middle lobe best here. So listening to the apices means you've missed the right middle lobe. That's why we make you do it in the gold standard way. And then you can also do it with the radial dial here and do it alphabetically, which I can't wrap my head around because I'm used to examining a person head to toe. At the end, when we ask you to get clinical feedback, you're not doing it in learning mode, so you won't see it. You'll just jump right to this. And then we ask you, what is the most significant active problem? I'm going to say, usually there's only one most significant, not maybe significant. And then you're looking to see whether the others are related, unrelated, unknown, or resolved. So your past medical history, the person has an abdominal scar in the right lower quadrant, that would be classified as resolved, maybe from a previous appendicitis. You're not going to get feedback here. It doesn't want me to skip that. And then what you're going to do is move on to, you won't see that, you're going to be asked to do your problem statement. You're not going to see the feedback, and then you're going to ask to determine the various categories. This is an opportunity when you're picking up a differential diagnosis to stop and think about what body systems might be involved. So really think carefully about it. I'm just going to grab something. You're not going to see the feedback because you're doing it in test mode. And then you need to find your differential diagnosis. There are 3 ways to do it. It's alphabetical. That's tedious as anything. I can type what I think is going on. This is an opportunity for me to look at key findings. I can do a search in the web. I can look through textbooks and get ideas. Or I can go into a file folder system and then look in particular things to see whether or not this might help me think about different types of problems. So we try to give you tools to try to figure out what's going on. Let's say she has pneumonia. And then the other thing that's a bit complicated is we give you multiple types of pneumonia or multiple types of things, and that can be confusing. We're trying to get you to start thinking more specifically of the symptoms. If a person is an IV drug abuser, HIV positive, presents in a certain classic way, then it might be pneumocystis. If they present, having been hospitalized following a stroke, and your physical findings are in the right middle lobe, then it's most likely aspiration pneumonia. If they're out and about in the community, such as she is, then it's probably community-acquired pneumonia. How they're presenting, you should try to figure it out. If I decide and I put down pneumonia and I see this, and I'm there like, dang, what is it? This is the opportunity that I could write all these different types of pneumonia down. I could close my case. I could go out. I could read little, paragraphs on each of these types of pneumonia. I could come back. I could look at my key findings, and then I could decide which was the most appropriate. So you can help yourself if you just, so when you ask me how much time does it take, a lot depends to play through a case. A lot depends on how much self-directed learning you need to do. There are certain cases, that if I was working through that, when I was interested in endocrinology, yeah, I knew lots about endocrinology. But you give me something, in peds, because I really wasn't interested in peds, I would have to do a lot more research in peds than in endocrine, just because what I typically like to read. So, you will find the same thing. You then move over, let's say she does have community-acquired pneumonia. When we're doing it in learning mode, we're going to get clinical feedback, but you don't get that. And then you get the corrected list from the author. You get to figure out which one is the leading, which one is the alternative, and the must not miss. The must not miss diagnoses are the ones that, if not diagnosed early, bad things happen to the patient. Sepsis, you can die of sepsis. You can die of thyrotoxic crisis. You can die of drug intoxication. And maybe pneumonia too. I don't know if all of them are must not miss or not. This is a gray zone. There is no perfect definition. The same disease in different people could be viewed as must not miss or not because of their ability to cope with the diagnosis. Walking pneumonia in a young, healthy teenager is different than walking pneumonia in a 95-year-old with coronary artery disease, COPD, and asthma. Totally different thing. You would not see the clinical feedback. You would go straight to the test, and then these are the tests that you have to associate. So if I want a 12 lead for septicemia, that's how I put it on. And you want to choose tests that help you rule in or rule out diagnoses. If it's a clinical diagnosis, such as bipolar disease, there's not a test that you can order that says, yes, they have bipolar disease. Then your job is, you might not have any tests associated with it. You're ruling out all the other organic causes, and you are left with your clinical diagnosis. Other tests, HIV drug abuser, recreational drug abuser, I might want to get an HIV test just to see if the status has changed. In a woman that I might be treating who is sexually active and fertile, I might get a pregnancy test because I would want to know, whether or not the person is pregnant. Do I listen always to the patient? I have to determine from my interaction with the patient the level of reliability, just like in the real world. So you do that. Again, you're not going to see the feedback because you're in test mode. And then you do get to review the test results. Pay attention to the little wormhole exercise here. and really take advantage of the fact that you know, spend some time looking at it. If you're not sure what all of these findings mean, then look them up. And with chest x-rays and other things, you can go to the report. So don't forget about this little icon up here. Again, if it's blue, look at it. This is the only icon that doesn't do anything. Finally, you have to put your dime down. You're not going to get to know whether you're right or wrong, and then you have to write your plan. And this is where the question was, can I write that on a different document and then just cut and paste it in? The answer is yes. Can I write it right here? The answer is yes. Can I pause, go out, do some research, come back and continue to write it? The answer is yes. I just closed down the case by pushing the hamburger menu and then relog back in. So I think we've covered all the things. And if you want to write notes to yourself, you've got this little push pin up here. You can push the pin and you can see this is a self-directed note. So if you want to first write something here as you're going through, it's a toggle switch. So you toggle it on and off by just saying return to case or go back to your notes to yourself. I personally always, when I was learning how to do a history and even a physical exam, created a sheet or a note card for myself, and I would tick through the things that I was doing. I also always would recommend that when you get your final results, I'm going to just write garbage in here, that you actually spend time to look at them. As frustrating as it might be, right then and there, you don't get to see all of this because you're in test, but if you go to see your evaluation, you do get to see what you did. And if you click on the history, you will get to see, you know, questions you asked, the questions you didn't ask. And if you click on the downward arrow, you can see the sequence of your questions. The challenge you should give yourself is to have all of the balls green in a nice, neat little row, so that you're not asking anything that didn't need to be asked, and you're not having big gaps of all these gray balls, which were considered not essential. They're not wrong. We don't take points away for asking extra questions, but we want you to learn to be efficient. Patients typically can put up with about 50, maybe 60 questions in a comprehensive exam, and after that, they start looking at you like you've got horns coming out of your head. They're starting to get tired and frustrated with all the questions. In a focused exam, it's probably closer to 25, and they wonder, what the hell are you doing? Because you just keep asking. So think about it when you went to see a clinician. How did they do it? What did you hear? You know, so first thing, your first way to figure out what your style is you've seen many different clinicians as a patient. Think about which ones you liked, which ones you didn't like. The key thing when I'm looking through to evaluate a student is I look, okay, 2 open-ended questions, great. The patient said something here and here. This next third question should have something to do with the answers in the first 2. And so should the 4th and the 5th and the 6th. Then I know you're listening to what your patient says, you're responding to it, you're getting clarification on it, you're doing old carts. The patient also feels they are being heard. And that is the most important thing for patients as far as bonding with the person providing clinical care, is they want to feel heard. So I think that's critical, and that is shown by the fact that you follow up with what they're telling you. So we've spent an hour, probably more than an hour, going over this. If you've got more questions, you can always toss in your questions to the help desk. If you want to have another session, please let the faculty know. They can request a session for their students at any point in time. Hopefully this has been helpful. I need to move on to my next lecture, so I wish I could give you more time, but this is all the time I have right now. So thank you for your attention and good luck.